Good evening to all of you. First of all, let me thank Dr. Unikrishnan sir and Team Chellaram for giving me this opportunity and Astra, the sponsors of this talk. So today I'm going to be speaking to you all about diabetes and sympathetic overactivity and how it can be a precursor, a silent precursor to coronary artery disease. So we all talk about cardiovascular events and how we can actually prevent those events in type 2 diabetes. But I think we rarely talk about this sympathetic overdrive that is seen in these patients of our type 2 diabetes. So let me start by sharing this particular case capsule with you. So he is Vijay. He's like your any other type 2 diabetic patient recently diagnosed. Okay, and he is worried that he may also be suffering from cardiac problems, as the case was with his mother. So he lost his mother at a young age because the mother died from a cardiac ailment, and she also had diabetes. So he is worried that he'll be following the same lines as that of his mother. And when we look at his parameters, then we can see that his HbA1c is uncontrolled. It is 8.4. He is slightly overweight with a BMI of 24. His blood pressures are well controlled. But we can't say the same about his cholesterol. His LDL value is quite high, 165. And he does complain of intermittent chest pain on exertion. His EGFR is 70, and he has some microalbuminuria. So, as you can see, he has got multiple risk factors for developing cardiovascular events. So, we all know that we need to bring his HbA1c to as close to normal as possible. That is, say, even up to 6.5 without causing hypoglycemia. We all know that we need to intensify the statin therapy if he is on, and we need to address the microalbuminuria part. But having done all this, do we address the risk completely, or are there still some other risk factors left? Then yes, there are. And the other one of the risk factors which is left is this sympathetic nervous system activation. So we know that increased SNS is can be seen in patients with diabetes, obesity due to insulin resistance. And besides insulin resistance, there are other causes. There are other comorbidities which can exist in our type 2 diabetic patients, like, say, for example, stress or depression. Some of them may be suffering from hypoglycemic episodes intermittently or sleep disorders. And all of this can lead to a SNS overdrive, which can then cause renal dysfunction as well as cardiac dysfunction. But is this sympathetic nervous system overdrive all bad? No. The answer is definitely a no, because we all know that we do require our SNS. So the sympathetic nervous system is required for us to maintain our heart rate, to maintain the cardiac output, to maintain the contractility of our heart, to maintain the volume of our blood. But if this SNS goes on overdrive, then it would lead to hypertension, then it would lead to endothelial dysfunction, platelet activation, hypertrophy, arrhythmogenicity, stiffening, coagulation, and all of these are nothing but predisposing factors for developing coronary artery disease. So, this is what we need to be aware of. Now, when we talk about sympathetic activity, is it actually elevated in our patients with diabetes and hypertension, and what do the studies tell us? So, this particular study has compared patients who were normotensives with diabetics, those who had only hypertension, and those who had both diabetes and hypertension. So, as we all can, guess, those patients who had normotension, they were the ones which with the least sympathetic activity. Okay, and those who had both diabetes and hypertension, those were the ones with the most sympathetic overactivity. So obviously the presence of diabetes and hypertension together intensifies this whole problem. And if you look at the Indian figures, so how many of our Indian hypertensives have sympathetic overactivity? Then this particular study done from India say puts the figure somewhere at around 62%. So more than 62% of Indian hypertensives have sympathetic overactivity. And this overactivity is further elevated when hypertension is clubbed with diabetes or smoking, or obesity, or mental stress. Now, mental stress is something I think which we all undergo at one or the other time point in our lives. And when we look at the survey findings, then it's quite, I wouldn't call it surprising, but it is definitely revealing to know that 90% of our Indian population say that they are suffering from some or the other form of stress. Then 3 out of 4 feel that they are not ready to talk about it with the medical professionals about the stress. 50% Indians feel that they do not spend sufficient time for social activities, either with friends or for their hobbies, because of the work related stress. And 50% of them feel that the stress could also be because of financial worries, because they are worried about taking care of their family's financial needs. And COVID has compounded this problem further, where 40% professionals are experiencing increased stress or anxiety due to COVID-19. So we all know that insulin resistance causes hyperinsulinemia, which then drives the norepinephrine release, and this norepinephrine release can then activate the plasma renin activity, the PRA, which then acts on the angiotensin 2, and angiotensin 2 can cause glomerular problems, nephropathy. Okay, we also know that norepinephrine release can directly cause ventricular arrhythmias. It can cause cardiac and coronary artery damage and increased blood pressure, plus non dipping at night, which is very classical. So, sympathetic nervous system activation not just acts on one particular organ, but it is acting on different organs. So, at the level of adrenals, as I've already told, it causes increased adrenaline release. At the levels of pancreas, it reduces the insulin release. Okay, at the level of liver, it produces glucose, so there's going to be more gluconeogenesis. At the level of the skeletal muscles, it is going to reduce the glucose uptake. At the level of fatty cells or the adipocytes, it is going to increase the substrate for gluconeogenesis by causing lipolysis. And at the level of kidney, it is going to activate the RAS system. So overall, whenever the sympathetic system goes on overdrive, we can see that all these things are what they are going to lead to is basically hyperglycemia. And how can we notice that our patients are having this sympathetic overdrive? We all know that patients continue to experience these symptoms, like tremors in hands, or fast speech, or restlessness, or inappropriate sweating. So these can be silent markers or silent symptoms of the sympathetic overdrive. But some of our patients may not have any of these symptoms, but the only sign that they have is tachycardia. So we should not neglect tachycardia. So elevated heart rate, as per this one particular study, elevated heart rate in those patients, particularly less than 55 years of age, it increased the cardiovascular, heart disease mortality by almost 2 times. The relative risk of a patient dying from a cardiac problem is almost 2 times if the patient's heart rate is higher, more than 100, as compared to that of a person whose heart rate is lower. And another study has shown a similar finding. So here in this particular study, there were beautiful study is the name of the study. So there were two subgroup of patients. So one in whom the heart rate was more than 70 beats per minute, and the other subgroup where the heart rate was less than 70 beats per minute. So when these two groups were compared, that group of patients who had a higher heart rate, they had almost 34% increased risk of dying from a cardiovascular event, 53% increased risk of admission for heart failure, 46% increased risk for admission for myocardial infarction, and 38% increased risk for needing a coronary revascularization. So, as you can see, all these p values are significant, and they tell us that elevated heart rate is something that we should not neglect. So now we have decided that we want to treat this sympathetic overactivity, but how can we actually do it? So these are the European Society of Cardiology guidelines, which recommend that beta blockers should be used as a first line of treatment, specifically when there are certain clinical situations like angina, post MI, heart failure, or for heart rate control. And this is a level 1A evidence. So, beta blockers should not be shied away from, and we should use it in this subset of patients. So, what do beta blockers do? So, beta blockers are going to inhibit the sympathetic stimulation. So, less sympathetic stimulation, less heart rate, less contractility, less need for myocardial oxygen, and hence the lesser incidence of developing a coronary artery disease. But does that actually, manifest, or has it been seen in trials? Then the answer is yes. And one of the beta blockers that we commonly use and has shown these benefits is metoprolol. So, what is the uniqueness of metoprolol? So, metoprolol, we all know, is rapidly and completely absorbed throughout the GI tract, including the distal regions. The half life of metoprolol is 3 to 4 hours, and hence we use extended release preparation. Its excretion is mainly through the hepatic route. There is no accumulation of the drug in late stage CKD patients, and there are no active metabolites. So, metoprolol reduces the sympathetic overactivity. There's an average reduction in the heart rate by around 14.5 beats per minute. So, this was shown in the live study. So, again, when the risk of cardiovascular deaths. So now we have decided to use metoprolol. What kind of metoprolol? Does that actually matter? So yes, it does. And for many of the other extended release metoprolol, what is being used is a gel-based matrix system. And in this gel-based matrix system, what happens is that it may not be an ideal choice because more than 90% of the drug gets released in the first 10 hours. Okay. But in Celokin XL, you have the zero order kinetics and the MUPS system, that is a multi unit pellet system. And this MUPS zero order kinetics best formula, it gives the desired constant plasma concentration for 24 hours. So, how does it do it? So here there are pellets which are enclosed in these micro capsules, and you have got several hundreds of these micro pellets in the one tablet, which are covered by one of the polymeric membrane. Okay, so each of these micro pellet acts as a diffusion cell, and it leads to a constant release of metoprolol succinate from the pellet during a 20-hour period, and absorption occurs during these at least 20 hours throughout the whole GI tract. So this unique system of MUPS, that is the multiple unit pellet system, it basically causes a slow release matrix tablet. It does not disintegrate, and the entire dose is consequently contained in one single unit during the GI transit. And this leads to basically an extended release formulation for Celokin XL. So, Celokin XL, the zero order kinetics. Why is it called as the zero order kinetics? Basically, it is not being affected by your meal or the gastric pH or because of the agitation. And throughout, it is able to maintain the 24-hour action. So, Celokin XL has got some benefits, that is, once a day administration, better compliance, therapeutic plasma concentration is smooth and uniform throughout the 24 hours. It has got a higher beta 1 selectivity and less side effects, higher degree of response among hypertensive patients, so therefore a better tolerability. And it, because of its specific outer membrane, which prevents its impact from food intake or pH or intestinal motility, so absorption is not interfered by any of these problems. So, to summarize, sympathetic overactivity is elevated in patients with diabetes, obesity, smoking, and stress. And this elevated heart rate increases the mortality in specifically in those patients of diabetes less than 55 years by almost two times. And metoprolol helps to reduce the sympathetic overactivity by reducing the heart rate by around 14.5 beats per minute. It reduces the incidence of sudden cardiac death by 30%, all cause mortality by 22%. And metoprolol, with its unique MUPS zero order kinetics prolonged release formulation, which is seen in Celocan XL, it provides a 24-hour duration of action, with its absorption being unaffected by food intake, pH of body fluids, and intestinal motility. Let me thank you all, and if there are any questions, we can discuss. Thank you.